is at Ann Arbor and is the director, medical director of kidney transplantation at the University of Michigan. She is originally from Panama, did her residency training and her fellowship training in the U.S. The fellowship completed, including a pathology fellowship at the Johns Hopkins, spent some time in Wisconsin before she moved then to Ann Arbor, where she's been for the last several years. Dr. Samaniego has a big interest in the immunologic mechanisms of kidney rejection and is interested in both antibody and T-cell mediated rejection, acute and chronic rejection, and the role of HLA in the development of the chronic rejection that occurs in virtually all patients who receive a kidney transplant. We've been doing kidney transplants now for over 50 years. I think many people consider it just sort of a routine. Okay, you get kidney failure, why don't you just go up and get a transplant? We have just as many obstacles, just as many hurdles to overcome in the year 2016 as we did back in the 1950s when transplant started. So I'm delighted to welcome Millie to speak.
Thank you, Eleanor. Thanks for the kind introduction, Eleanor. And move this a little down. Dr. Lederer was a resident at Baylor, where I also did my residency, and she was a hero there. How can I get my presentation up? Well, thank you. I hope the last time I saw these two school items logos together, things did not work out very well for the maize and blue. So I hope that this lecture goes a whole lot better. Thanks for the invitation. I have no conflict of interest. This is a very old slide of mine, but I like it very much because it's have quite a little bit of impact when we give this type of lecture to the general medical community and other non-nephrology specialties. This was a full-page spread that the National Kidney Foundation published at USA Today in 2005, making the statement that 1 in 9 Americans has chronic kidney disease. And the first part of this lecture is going to be a brief introduction to the current status of kidney disease, and then we're going to transition into kidney transplantation as the modality of renal replacement of choice. Okay? So this is from the USRDS 2015 ADR, and shows you that from 1988 all the way to 2012, we have seen an increase in the number of patients that have stage 3 CKD. We see that patients that are early stages are relatively stable, but obviously an increase in stage 3 requires progression of these patients from 1 to 3. Now, there is a dramatic fall in stages 4 and 5. And the reason for that is that the majority of patients in this stage 3 will die due to coronary artery disease or other cardiovascular complications and will not make it to stage 4, stage 5. So if you see a dialysis patient, think that's the cream of the crop that you're dealing with as far as kidney disease is concerned. In terms of other interesting aspects of the disease, first of all, chronic kidney disease is not a sexy disease. You can count in one hand the celebrities that get a kidney transplant or are known to have kidney disease. I'm pretty sure you can quote at least one or two of those. But CKD is a disease of poor people, of racial and ethnic minorities, and there is quite a little bit of lack of knowledge or medical ignorance in general about the management of CKD, diagnosis, and natural history of the disease. In addition to that, chronic kidney disease is an aging disease. As you can see here, the majority of patients in 2013, or a substantial number of those patients, were over the age of 65. And as we will see in a couple of slides, the age group above 60 years of age is the fastest growing group of patients entering dialysis and also joining the waiting list for kidney transplantation. In addition to that, this is something that is important to all of us. CKD and end-stage kidney disease, for the representation in the general population, is an extremely expensive disease. These are the costs in billions in the Medicare expenditure. These are the expenditure in low-income patients. And you can see that the amount of Medicare dollars spent in low-income patients or no low-income patients in general medicine is overcome by the amount of dollars that is spent in the treatment of any stage of CKD, and furthermore in patients that develop end-stage kidney disease and require dialysis or kidney transplantation. What is probably less encouraging is that we will continue to have an increase in the number of end-stage kidney disease, at least in the years predicted until 2050, although we hope that at one point in time it will reach a plateau. The other aspect that is important here in this slide is that although patients can survive fairly well and much better than when I was in training on dialysis and peritoneal dialysis, transplantation is the most cost-effective form of kidney transplantation. Not only allows for lower costs of health care, but it also allows for the patient to be integrated into the community and the workforce. Therefore, they can start contributing to some of those dollars that were spent in their medical care when they were on dialysis. And how do we know that kidney transplantation is better than dialysis? Bob Wolf at the University of Michigan, now many years ago, published what we believe is the definitive manuscript demonstrated that primary deceased donor kidney transplantation provide more survival and better quality of life for patients with end-stage kidney disease compared to dialysis. This is now a graph that is included in pretty much all the transplant conferences around the world. And if you look at it, you can tell several interesting aspects of it. Okay, during the first 106 days after a kidney transplant, the risk of dying is about 3 times the risk of staying on dialysis. The survival does not become equal until about 244 days after transplantation. But in order to derive survival benefit and savings and better quality of life, the patient must survive 1 year after transplantation. Otherwise, this will be not only a reason for poor allocation of organs as the organ goes away with the patient that dies, but currently is a reason for your transplant program to be in CMS jail and face the risk of having it closed. So these are adaptations from the different graphs that are included in Bob's paper. These are all patients on dialysis and the mortality rate for 100 patient year in a patient on dialysis compared to 6.3 per 100 patient years in patients on the waiting list, which goes to show the bias of physicians taking care of patients on dialysis, where only the best and fittest dialysis patients get listed. But there is a dramatic fall in mortality once these patients receive their first deceased donor transplant. This study, unfortunately, has not been done again for living donors. There are similar studies, but this data only pertains to primary deceased donor transplants. So who are the patients that benefit the most? As opposed to what many people think, diabetics are the ones that benefit the most from kidney transplantation, and not only from a first kidney transplant, but also from retransplantation. Compared to staying on dialysis, the survival or the years of transplant in a patient that is between 20 and 40 years of age and has diabetes goes up from 8 years on dialysis to a projected lifetime of 25 years. So it is a dramatic impact in terms of survival. You also see it in the group of people that are contributing the most to the society, the age of 40 to 60. And again, the diabetics derive a benefit from 8 years in the projected life on dialysis to 22 years when the patient receives a kidney transplant. Interestingly, what you see here as well is that between 60 and 74 years of age, there are not too many diabetics that have survived on dialysis at that time. That's why you don't see the diabetic statistic here. But there is also a benefit. The benefit is substantially more modest than what you see in the other age groups, but it provides quite a bit of a quality of life improvement in this age group. So when I go to my clinic and go to do transplant evaluations, this is usually the type of patient that I see either in the clinic or patients that are coming for maintenance on the waiting list. In the state of Michigan, the average waiting time, the median waiting time is approximately 5 years. But if you are of blood type B, the median time will be about 7. And as you know, the blood type B is highly prevalent in the African American community. These patients will have a long waiting time, and some of them will die waiting for a kidney transplant, as the vintage of dialysis has quite an impact on them. And this is important for you to know, because with the current organ allocations, the first patients that will be transplanted are the patients that have the longest time on the waiting list. So the morbidity and mortality of those patients is going to be different. And I am pretty certain that if Bob went to do his study again, it will take a little longer than 106 days to decrease the risk of dying compared to dialysis. Our patients are more complicated. We don't take care anymore of the PKD, congenital urological abnormalities, and GN patients. Most likely we're taking care of the elderly, obese patients with cardiovascular morbidity, and at the same time patients that have quite a challenging socioeconomic environment, mainly because, as we said before, it is a disease of poor people. And if you live in the state of Michigan, where the economy has been depressed now for over 15 years, this situation is even more dramatic in our dialysis population. So there are many other medical and immunological factors that make the management of the kidney transplant candidate and recipient quite challenging. But for the purposes of today's lecture, we're going to be talking about elderly and obese patients, patients with history of non-compliance, and how the support of immunosuppression costs contribute to, or lack thereof, contributes to non-compliance and patients without family support and transportation issues. So let's see about what's happening with the elderly. As you saw in the previous tables, there is a benefit in survival of approximately 5 years compared to dialysis if the patient gets transplanted. But we have a societal challenge. And this challenge is that the elderly population over the age of 65, although the AARP started sending me some literature before 50, that made me feel really well. It is going to continue to increase until the year 2050, and it's estimated that close to 90% of the population is going to be over the age of 65 by the year 2050. So there are all kinds of old people. All the people I'm going to show you here are over the age of 70. You can see Raquel Welch, Sophia Loren. You know who she is. But this is my patient over the age of 65. This is the patient that comes to my clinic. Usually, if they come with a walker, yay, they came with a walker. But they usually come on a wheelchair with oxygen tanks, etc. And they actually get very disappointed when you tell them that you could not give them a transplant. Now, what are we going to do in terms of transplanting the elderly when you can really see here that the fastest group of patients with end-stage kidney disease are older than 65 years old? Are we going to deny the best modality of care for end-stage kidney disease to a CEO of a 500 Fortune company because he is in the age of 65? What makes one life more valuable over the other? Are we going to start or use the kidney transplant model as a model of rationing of medical care? These are all questions that we deal with from the ethical standpoint and the medical management all the time. So in general, I like the Canadians. The Canadians are very clear in their principles. They don't fight with each other. They work together, highly collegial. They have national healthcare system, and they are very definitive in their recommendations. Age is not a contraindication to transplantation in the country of Canada. But in all the renal transplant candidates, it's very reasonable to determine a priori what is the probability of that patient surviving. In other words, when I have my 72-year-old patient that comes to the clinic, the one I saw yesterday, and she's diabetic, has peripheral vascular disease, and had cryptococcal meningitis. I'm sitting with her and I said, Mrs. So-and-so, I am so happy for you. And she's looking at me with this face. Said, because in spite everything, you survived, which indicates that your patient selection was adequate. And once you're done with your fluconazole, you're going to go on and have a pretty healthy life, provided you stop playing with those little pigeons you have at home. So what is the problem with the elderly? One of the problems is that with the current deceased donor allocation rules, patients over the age of 50 are going to receive, or the probability of a patient over the age of 50 of being transplanted is going to be lower than what it was before December 4th, 2014, when the organ allocation rules were initiated. There is a tremendous benefit towards very young patients, and to the 30 to 50-year-old population, but this also brings about some ethical conundrum there. The young patients, patients between the age of 13 and 30, have the worst graft survival of all age groups due to non-compliance. Then these patients become sensitized, develop antibodies against the transplant, and are very hard to be retransplanted. In the elderly patient, in terms of graft survival, the graft survival is, if the patient is well selected, is not that much different than younger groups if it is a non-sensor graft survival. What we know is that in the elderly, the graft loss is not due to rejection, but it is because the patient dies. And this is what is so important to try to define what is the probability of survival after transplantation. And this is the same curve, but now adapted for elderly patients. You see here the equal risk compared to mortality on dialysis is achieved about 125 days after the transplant. Not that much different than what happens to patients in the waiting list that are in other groups. But the time in which they start deriving real benefit of survival and they don't get into the hospital, they have been able to manage their infections and overcome their infections, is longer. In the general population is a year. Here is about twice that time. So patient selection in the elderly is extremely important. And as is shown here again, all these elderly individuals will derive some benefits. The benefit in survival will be better in the younger group, with the hope that these patients are taking their immunosuppression. And this is why the current organ allocations are preferring the younger age groups compared to the elderly. If you talk to a pediatric transplant nephrologist, they will tell you that these individuals have just started to live. They have a life ahead of them. These ones already lived their life. That is their argument as to why the younger individuals need to have a better access to kidney transplantation. Of course, that is the sort of argument at all meetings. Now, one important point is that the survival benefit of transplantation in all folks depend on how fast they are referred to transplantation and are transplanted after starting dialysis. So if I have a 72-year-old patient that is blood type B and started dialysis a month before, I just tell Mr. So-and-so, you're doing so good on dialysis, you should stay on dialysis. Because at age 80, when your transplant or your organ becomes available, we are not going to give you a transplant. And you are also already overcoming the chances of dying in dialysis. So why to give them a transplant that eventually will shorten their lives? There is also an important aspect, and we are all internists, and during my training, I did a rotation in geriatrics at the VA, and I just hated it. And it's so difficult, geriatrics. It's a beautiful specialty, but it's a do no harm specialty. And, if I am in transplantation, it's not because I'm very conservative, right? So have to back out and just not prescribe the first medication that comes to mind is very hard. So the perioperative management of the elderly is extremely important. The best outcomes are always obtained with living donors. This is one advice we give to our patients. Do you have a friend from high school that is still around, you go out on cruises, etc., that wants to give you a kidney? Because for a 72-year-old individual, getting a kidney from a 68-year-old person is perfectly fine, okay? Not the same if the recipient is 40 years of age. Now, the chances of mortality and the days taken to have the same survival as on dialysis changes depending with the quality of the organ. This is on a standard deceased donor transplant, and this is on the old nomenclature of the expanded criteria donor, who are patients over the age of 50 that at least have 3 criteria: diabetes, hypertension, death from stroke, in addition to others, or all patients over the age of 60 are considered to have the expanded criteria donors. And again, the outcomes are not as good as one will expect with the living donors. If I went to give you a recommendation, where what I will say is get your first and fittest 72-year-old recipient that has a living donor. That's the probability of doing the best if you are an older individual. Now, one thing I want to bring up here is that chronological age is not physiological age. These are old folks that probably run faster than I do compared to this individual. And this also applies to the younger patients. When you see the 45 or 40-year-old type 1 diabetic that has been diabetic for 35 years, that come with amputations, blind, and already had a bypass and 2 stents, that patient is 45, but this is that patient. The physiological age of that patient is as bad as the chronological age of any of these guys. So all of this also comes into consideration. So when we are trying to transplant the elderly, we need to go back to be geriatricians. And most of the time, what we need to do is to ask the fellows to come and work with us and evaluate their functional status. But in addition, we need to evaluate very much the socioeconomic situation that the patient is on and make sure we are not transplanting a demented patient. Transplantation in a demented patient is going to shorten their survival quite substantially, and it is much better for a demented patient or abnormalities in the neurocognitive function to stay on dialysis. And the evaluation of the functional status could be as simple as walking fast down the aisle, measure the time that they take in walking 100 feet without any kind of assistance, or just shaking their hand. A handshake can give you pretty good information about the functional status of an elderly patient. The other issue we have with the old recipient is what are we going to do with their immunosuppression? As shown in this diagram, although the risk of acute rejection is lower in older recipients, then they still reject, and we also have to overcome the barrier of infection with or without rejection. And in this cartoon, what you see are the effects that age and senescence has in the most important effectors of the immune system, in the production of antibodies, cellular responses, but also in the potential of inducing some kind of tolerance in this patient where the T regulatory cells that are the natural mechanism to try to control our immune responses and also alloreactive responses is also decreased. And furthermore, although you see many different interventions in terms of the management of immunosuppressions on this table, we really do not know which is the best because we have never done good trials trying to demonstrate which is the best regimen for immunosuppression. So we move from the old guys to the obese guys. And you know that about 60 million U.S. adults, and this is from the CDC webpage, are obese. This is, and you can see your state here. Back in 2007, 25 to 29% of patients in the state of Kentucky were, I would say, were obese, considered to be obese by BMI equal or greater than 30. Now, if you go back and see over here, you got a little bit better, but actually you got a little bit worse. Now, there is quite a little bit of increase. 30 to 35% of your population in the state of Kentucky is considered to be obese. Also, the prevalence of kidney disease in your state is not as high as it is in other states of the nation, is not low either. And when you consider the impact of obesity in kidney disease and the fact that the majority of African Americans have at least more than 35% are considered to be obese, and that Hispanics as well have a high percentage of obesity, and both racial and ethnic groups are associated with kidney disease, you can see that the likelihood of you seeing an obese patient in a transplant clinic is an everyday effect. And the impact of those patients being in the dialysis unit is also similar. Well, what is the obesity paradox? In the general population, people who are very, very, very thin, you know, all those models, may have greater mortality. But the worst mortality is observed in the patients that have morbid obesity over 40 of BMI. But in hemodialysis patients, obese patients, being obese is good or is not as bad as in the general population. And there is this concept of the healthy obese and the non-healthy obese. Probably remember, they are on dialysis. They are the cream of the crop. So these are probably nice obese patients because all the bad ones already died, right? So what happens with transplantation? In transplantation is similar. You see higher mortality, relative risk of mortality in people with very low BMI. We struggle with some of our young females, and we guarantee that there are no eating disorders when they come for transplantation, and only goes back up and goes significantly up over all the other levels of BMI when it is morbid obesity over the age of 36. So why to deny the access to transplantation to a patient that is obese when we see that the candidate mortality risk is fairly low in the patients that are obese? However, this selection needs to be very careful because the transplant mortality risk in these patients is higher. Again, it's patient selection, and more selection. It's again an analysis similar to what Bob Wolf did back in 1999. And here what we're doing is comparing obese versus non-obese patients, patients on the list, recipients of deceased donor and living donors who are obese. And there is a reduction in the hazard of mortality with transplantation in patients who are obese, and is not too much different than what we see in patients that are non-obese that also receive a deceased donor transplant. It's exactly the same reduction in hazard. Okay. The days, of course, it's going to take longer for the obese patient to decrease their mortality, primarily because they get into quite a bit of surgical complications and wound issues. We usually said that for certain BMI, we just put the wound vac right there before we close the patient, because we know that this is going to be a problem. To finish, I want to talk to you a little bit about the socioeconomic aspects of kidney transplantation. And before I was recruited to Michigan, I spent 5 years in the University of Wisconsin in Madison, who also has bad memories with Louisville for many reasons. But this goes and shows the comparison in the population. This was in 2010. By the way, the state of Michigan was the only state in the nation that actually lost population in the last census. Okay? We had a decrease of minus 0.6%. The composition, the racial composition in both states, much more a Caucasian population in Wisconsin than in Michigan, and as expected, and this is due to the largest proportion of African Americans in the state of Michigan. And surprisingly, apparently, Latinos like the worst weather in Wisconsin. It's not a significant difference, but there is at least 1.5% in difference. So what is this curve? This curve represents the percent of unemployment in the state of Michigan, and I have to see over here from 2005 till 2014. And it reached a peak in 2009, which was the year that I joined the University of Michigan. I really don't know. But anyways, the percentage of the population in Michigan compared to Wisconsin is about 3% higher. And the percentage of unemployment today is about 1% higher as well. And the reason why I was interested in comparing Michigan and Wisconsin is because they are next to each other. They share a nice lake. But at the same time, I saw that it was so much easier to take care of the Wisconsinite than it was to take care of the Michiganian patient. It was, and obviously, the socioeconomic aspect of it had to do quite a little bit. And here again, 7.1% in 2005, increasing all the way to 15% in the year 2009. So this is a map of the United States that shows what is the socioeconomic risk of a kidney transplant candidate according to states, where light white is good, whereas gray and black is bad. So you can see that the state of Wisconsin had a mid to low risk in terms of socioeconomic parameters. These are all milk farmers. And the state of Michigan also has a much greater socioeconomic status. And you can see the distribution of risk among the population. And this has the potential of have a serious impact in your transplant outcomes. Now, what are the factors that Jesse Schultz was looking at this? He was demonstrated that patients that have a greater risk, states with a greater community risk scores, more patients died on the waiting list, less patients received a living donor transplant, more patients in the high-risk category were removed from the waiting list, less were transplanted preemptively prior to starting hemodialysis, and they were clear for transplantation, but immediately were put on status 7, which is the inactive status, which means the patient is in the hospital sick, for most. So it goes to show the impact that the social environment can have in your patients. And this, again, is the summary now in a table format of the impact of this community risk in unadjusted and adjusted hazards in terms of predicting graft survival and patient mortality. And what we know is that the farthest the patient lives from the transplant center, the greater is going to be the mortality. In addition to that, we have the issue of adherence in the patients that have a poor socioeconomic status, and this is the range of graft loss associated with non-adherence that can go from 16 to almost 45% in the different studies, with the average being, or the range being between 26 to 36 in the majority of the studies. In patients that lose their transplant due to chronic rejection, 47% of those patients can be demonstrated to be non-adherent to their immunosuppression. And every year, we lose approximately 11 to 15% of transplants of grafts in the United States, primarily due to medical non-compliance. And is the non-compliant patient a bad patient, a mean patient? No. The problem is we do not provide immunosuppression for these patients beyond year 3 post-transplant. So being successful in transplantation immediately requires that after 3 years, you need to become unsuccessful again, return to dialysis, and stop working and start adding dollars to the healthcare system. And what you can see here, again, is that since Medicare covers for the medications of these patients, again, the patients that are going to be more affected are the patients with low income subsidy. And this is also starting to affect even patients that do not have a low income, the middle class, the retirees. This is a problem for our patients. So I decided when I was seeing these problems in Michigan that I needed to go back and read or remember when I was starting medical school. It was that first, hospital admission was the failure of preventive medicine and good outpatient care, that equal health to all is access, that we needed to decentralize medical care, and to decentralize medical care, we created a network of outreach clinics. Okay? And the goals were to improve and expedite the listing of these patients so they will get a faster opportunity to get transplanted, educate them, and make sure that when they came to the outreach clinics, they brought potential living donors, and also improve the rate of non-adherence and reduce the preventable admissions. Right now, we have 5 outreach clinics that cover pretty much a big chunk, 2/3 of the state of Michigan. We are not paid for this. This is done out of the commitment of the transplant nephrologist, of going once a week to one of these places. The one you have to drive the least is about 30 minutes. The one you have to drive the most is about 2.5 hours back and forth, which is here right on the lake, Muskegon. I volunteer for Muskegon because it's a really nice town, and it's just a beautiful, beautiful town. And that's what we're doing now, trying to track the statistics of these clinics. What we have demonstrated already is that since we opened the first clinic in 2009, we now have seen an increase by about 250 referrals per year. And a couple of years ago, we had about 800. Last year, we had 1,100. And we have seen that at the expense primarily of the outreach clinics. That's where the patients are coming. So in summary, kidney transplantation is the best renal replacement therapy, but it is not without risk. Hence, selection of the kidney transplant recipient is the key to the a successful transplant. The assessment of transplant-related risk does not follow the rules of common sense. You would think that an old guy and an obese patient would not do well, but that's not what the data demonstrates. And I will conclude that medical, societal, and economic factors are, in 2016, essential in the success of transplantation, that being young, being nice, or being skinny is not an indication for transplantation. The same way that being old, being mean, or being obese is not a contraindication. I will take questions. Thank you.
Thanks, Millie. So before we take questions, I'd like to make a couple of comments. First of all, I'd like to emphasize the graph showing the differences in the prevalence of CKD3 and CKD4. Chronic kidney disease is a metabolic illness that affects all aspects of the body, very similar to diabetes, and is quite frankly just as severe a cardiovascular risk factor as diabetes is. The other thing I wanted to point out is you saw for many of her slides, down at the bottom it said US RDS. This is a national database that is required by all people who do dialysis to submit the data on their dialysis patients. This has been in effect for how many years?
I think it started in 68.
So this is a huge database that for individuals who are interested in doing epidemiologic and outcomes type research, this is a fantastic database, and everything that we know about chronic kidney disease and dialysis really comes from this database. I have one question first. So you commented that for older donors, a living donor kidney transplant was ideal. Can you make some comments about perhaps the risks to the donors?
That's a very good question. And the way we look at it is that if you made it to over age 60 without kidney disease, you're probably going to meet your maker without kidney failure, with a single kidney. The risk is greater if you deal with younger patients. For instance, a 40-year-old obese African-American man whose family, second, 3 generations have had kidney disease and of course have the genetic risk. Or the 45-year-old obese woman who had gestational diabetes and who's also having family with history of diabetes. The risk is much greater. We had sometimes pushed the envelope in the older donors. The mortality of a donor is very low, including the old folks. Is usually what the statistic we quote is that it's more likely that you die today driving to your home than by donating a kidney transplant. So in the older guys, provided you have good surgeons, you have done a good workup, even hemoglobin A1Cs of 6 we have taken. Because we know that if you are 65 and you have a hemoglobin A1 6, even if you were to develop diabetes, that's not going to cause your death at that time, unless you have other morbidities that suggest that you had been diabetic for a longer period of time, and we make sure we exclude those. We also take hypertensive patients as donors, usually over the age of 55, regardless of the race, and those patients also do fairly well, and the recipients do fairly well. It's always age matching in these guys.
So you made a big point of risk stratification. Do you have a tool or a calculator where you separate out these 45 or 76 years old and you say, man, your score is too low, you're like, have you ever seen anything wrong?
I'm so glad you asked that question. I was going to show you that and decided not to, but we are working with a group that was initiated by biostatisticians, a transplant surgeon, and nurse coordinators. And they have developed a computer algorithm. And in the computer algorithm, you can calculate the outcome of that patient, graft, and patient survival on the basis, on the characteristics of that patient at one point of their dialysis history. So if the patient comes for the first evaluation, I can enter all the characteristics, hemoglobin A1C, PTH, history of diabetes, malignancies, socioeconomic status, compliance, all kind of different variables. And then at the end, give me graphs and tables with the probabilities of graft and patient survival. So to give you an example, I have a 41-year-old diabetic, has calcified all his iliac vessels, had a bypass, and already has 3 stents. When I enter his information, he would live longer on dialysis than if he got a kidney transplant. So that's why these tools are so important. Now, the tool may be wrong, but the only way to do it is to validate it by using it. And it's also good on the other side. I had this obese patient in the mid-60s that I thought I was going to rule out. No doubt I'm going to rule out this guy. And actually his outcome based on the program was pretty decent. Definitely did not increase did not show increased risk of mortality over dialysis. So I don't know if that answers your question. Huh? It's in the works. It's in the works. It has to be validated. The Canadians, again, have come up with a list, check marks, that you can use to determine the mortality. But I don't think that, as much as I like them, you can apply the risk factors of a Canadian individual to the African American patient from downtown Detroit. You know, even when we can see Canada from the Detroit River, but we cannot compare them. So it's in the process. It's in the process. Yes. Mm-hmm. Can you repeat the last part? Oh, okay. Which is the best parameter? You're right. BMI is not the best. The best is the waist-hip ratio and the abdominal circumference. We do get those, and we have been accumulating those for years and years. We have never looked at the data. There are other patients, and this was an interesting case we were just discussing yesterday on my way here, is a 72-year-old woman, non-diabetic, no cardiac disease, that had a gastric sleeve, has a living donor, wants to get transplanted right away, okay? So I wasn't aware, she lost already 40 kilos. I was so happy, I get her transplanted. But in this patient, they did a CT of the abdomen, and the panels were still so big that was obvious that she needed to lose much more weight to avoid the complications. We also advise the bariatric surgery to many of these patients, mainly the younger ones. But you need to be aware that if they have a living donor, they cannot be operated right away. You need to wait at least 6 to 8 months for them to recover. And also, we prefer the sleeve over the Roux-en-Y because of the issues of kidney stones and oxalate absorption, and they also get a lot of diarrhea with immunosuppressants. You're right. Waist-hip ratio is the way to go. Luis?
One question, because of this long waiting time that we have with patients waiting for kidneys, for cadaveric kidneys,
Mm-hmm.
Many of them do have hepatitis C, as you know. And one of the dilemmas we have is to treat them now while they are waiting, knowing
These are patients.
Repeat the question.
Can you repeat the question because I've.
Well, patients who you know they are going to wait a long time,
Uh-huh.
if you treat them now, they will not have access to C-positive kidney.
Uh-huh. So these are patients with kidney disease, let's say glomerular disease.
That's right. Well, no, no, in general.
In general.
They have both disorders. If you clear hepatitis C now, they will not have.
Oh.
They will not be offered a C-positive organ. And I don't know what is the proportion of C-positive organs.
No. Well, that's a great question as well. We, in general, we transplant them and we list them. We know we cannot get them treated when they are on dialysis. But as soon as they get transplanted, within a week or two, they go to hepatology and they start being treated with the cocktail. Now, it is always good to list them unless you know they have portal hypertension. Many times these patients are very stable liver disease. They don't have low platelets, they are synthetically normal. We always measure the pressures though. We do the manometry, that is fine. That patient can be listed for a kidney right away, but requires evaluation over time. Are the ones who have portal hypertension, and those are quite it's not a small percentage of patients. And then you send them to the hepatologist and they said, oh, well, we cannot give him a liver yet. Those we do not clear for transplantation because we know if they get a transplant, they very likely are going to get into hemodynamic problems, mainly if they have delayed graft function. There is quite a risk for primary non-function on those patients with ascites and portal hypertension. There is increased pressure in the renal vein, and they all end up having primary non-function. But the response to the cocktail in hepatitis C in the kidney transplant is amazing. We even had patients with cryoglobulinemia that you give them, it's fantastic. We live in great times. Okay, thank you.
So it is a tradition that everybody who comes here gets their own Louisville slugger. And this one says, Milagros Samaniego, MD, Medicine Grand Rounds, University of Louisville, February the 25th, 2016. Thank you very much for your presentation.
Appreciate it. Good. I'm a slugger.
Your slugger, that's right. Okay, so the guy who took the picture is going to come, the guy who jumped right in and comes down and takes a picture. So Jason, where are you?
I saw him standing there.
Yeah, he'll be there. So